Maranhão, mais de 330 mil quilômetros de território.
Estado maior que muitos países.
Um desafio: como levar a educação de qualidade? Democratizar o acesso ao conhecimento.
E transformar vidas.
EAD UEMA,
20 anos.
Diminuindo distâncias.
E construindo história.
Vinte anos de educação à distância na UEMA. 20 anos transformando vidas, criando oportunidades para os maranhenses. A UEMA, por meio do Núcleo de Tecnologias para a Educação, tem levado uma formação sólida e de qualidade para todas as regiões do estado do Maranhão. Já são mais de 50 mil novos profissionais formados ao longo desses 20 anos de experiência da UEMA na educação à distância, democratizando o acesso ao ensino superior, promovendo inclusão, criando esperança para todos os maranhenses. Essa é a UEMA, que renova o seu compromisso com todo o estado do Maranhão, com o compromisso de fortalecer a educação à distância como grande instrumento de transformação educacional do nosso estado. Parabéns ao UEMA, parabéns à educação à distância, parabéns ao estado do Maranhão.
Good afternoon. It's a pleasure to hear from philosopher Dr. Markéta Nováková on very important topics such as relapsing fever, Lyme disease, and syphilis on diagnostic techniques. Now I'm gonna to read about her biography. Microbiologist who finished her philosophy doc in rickettsial infection of ticks at the University of Veterinary and Pharmaceutical Sciences in the Czech Republic, under the supervision of Professor Ivan Literaki. During her internship at the Universidade de São Paulo, under the supervision of Professor Marcelo Bahia Labruna and Professor Dr. Francisco Borges Costa, she isolated rickettsia from ticks and performed animal experimental infections and molecular characterization of the isolates. Currently, Markéta works at the Department of Biology, Masaryk University, in Brno, the Czech Republic, with Professor David. And her research is focused on spirochete of the genera Treponema and Borrelia. She studies dissemination of treponemas in experimental infected laboratory habitats and genetic diversity of Borrelia miyamotoi. Hi, Markéta, how are you?
fine. And I thank you for the very nice introduction.
Oh. Let's talk about in Portuguese. You understand very well. It's possible.
É possível. Porque o professor Francisco Borges Costa foi o meu professor durante os meus estágios na Universidade de São Paulo. Eu tenho memórias bonitas deste período.
Thank you very much. Muito obrigado, Markéta, pelas suas palavras. Vamos começar com sua apresentação.
Vamos. So, hello to everybody. I will now speak in English. The topic of this presentation are challenges in the diagnostics of relapsing fever, Lyme disease, and syphilis in public health. Firstly, I will tell about the pathogens. These bacteria are called spirochetes altogether due to their spiral shape. And two of the diseases are zoonoses. A zoonosis is a disease that is transmitted from animal to humans. So tick-borne relapsing fever and Lyme disease are zoonoses. And the third one is anthroponosis. And this is of course, syphilis, sexual transmitted disease. Now let's turn to the first two diseases. Vectors of relapsing fevers and Lyme disease are ticks. And more or less, it's true that all tick-borne relapsing fevers are transmitted by soft ticks, except some exceptions. You can see a soft tick in the right picture. And in contrary, Lyme disease is solely transmitted by hard ticks, which is shown in the left picture. This is the well-known Ixodes ricinus species. Relapsing fevers are distributed around the world, especially it was known for the species transmitted by Ornithodoros, that they were present in large part of North America, some parts of South America, such as Venezuela or part of Brazil. And in the Old World, they were known for centuries to be present in some parts of Africa, Middle East. However, Europe, there is only the south part of the Iberian Peninsula. It means part of Portugal and Spain, where it has been known that there is Borrelia hispanica, but the rest of the Europe have been known to be free of tick-borne relapsing fevers. So, in general, it can be said that these tick-borne diseases are poorly known in many countries, and especially in Europe. Now, the distribution of Lyme disease, it's generally can be said that it's present only in the northern hemisphere. And here are the main vectors. It means tick species of the complex Ixodes ricinus species complex. And Borrelia are traditionally divided into these two groups, relapsing fever group and Lyme disease group. And also phylogenetically, based on genetic sequence, these two groups cluster separately. And moreover, it's true that a relapsing fever group Borrelia are transmitted by soft ticks and Lyme disease group by hard ticks. But there are some exceptions, such as Borrelia miyamotoi. This Borrelia escaped to notice to scientists and to physicians until several decades ago. And it's very interesting that it's presented in large areas in the northern hemisphere in the same vectors actually as of the Lyme disease. So now you see the same map, but we can add that this is the distribution of vectors of Lyme disease Borrelia, but also of Borrelia miyamotoi. It has been firstly described in Japan in 1995, only the existence, but later in 2011, Professor Platonov from Russia described a series of cases of group of patients that suffered for a viral-like febrile disease. Although Borrelia miyamotoi belongs to the relapsing fever group, the relapses are not so common. And it is also very interesting that this Borrelia is transmitted transovarially from mothers of the ticks to its eggs. I made this picture. I hope that you like it, as I like especially the deer. So before, it was generally believed that larvae of Ixodes ticks are free of Borrelia, that they cannot transmit Borrelia to humans. But this is not true now, because now we know that larvae of Ixodes ticks can contain Borrelia miyamotoi and they can transmit these bacteria to humans. So now we must be also aware of these tiny larvae. Now we move finally to the diagnostics, which is the topic of this presentation. If we compare diagnostics of relapsing fevers and Lyme disease, we can say that for relapsing fevers, it's true that because they develop high bacteremia in blood, we can detect them in the blood directly by methods like microscopy or PCR, polymerase chain reaction. Direct methods means that we detect the pathogen itself. And for this reason, serology has been overlooked. It was not so important because physicians were able to diagnose tick-borne relapsing fevers by direct methods. But with the discovery of Borrelia miyamotoi, nowadays there is a lot of focus on developing serologic tests that would distinguish between relapsing fevers and Lyme disease, because now we know that they overlap with Lyme disease and also other relapsing fever Borrelia. And for Lyme disease is the contrary. Lyme disease develops, during Lyme disease, only transient bacteremia develops in the blood, so direct methods are not sensitive enough to detect Lyme disease. So indirect methods such as serology play central role in diagnostics of Lyme disease. Now, more details about the tick-borne relapsing fevers and diagnostics. So again, I will repeat that the direct detection has been the most widely used, and it is most widely used so far. This means microscopy in dark field, culture, which is quite expensive. This is not so very much used. And then a variety of polymerase chain reactions, such as specific quantitative PCRs, multiplex quantitative PCRs, etc. And with the indirect detections, there are no serological tests available commercially, but scientists already tried to detect relapsing fevers on subsets of patients that suffered for febrile diseases, recurrent fevers, or that reported tick bite, and so on. So they were attempts to use whole cell lysates of Borrelia hermsii, for example. But with these whole cell lysates, there is the problem that because they contain so many antigens, they can cross-react with or other Borrelia of the relapsing fever group, or also with Lyme disease Borrelia. So this is not so specific. So there were other experiments with using GLPQ immunoreactive protein. This protein is present only in relapsing fever Borrelia. So it will always be negative for Lyme disease Borrelia. But then the sensitivity was lower, so scientists tried to add other proteins. So there were attempts to use GLPQ in combination with 4 antigenic variable major proteins. With this attempt, these authors reach a higher sensitivity and specificity. And there are also other experiments with using monoclonal antibodies for detection of Borrelia crossidurae, which were very useful for rapid diagnosis of this pathogen in tropical areas. Now let's move to diagnostics of Lyme disease. It's probably known to you that when someone gets infected, the body reacts with developing immunoglobulins. Firstly, in first weeks, it's IgM, and later, in weeks or months, IgG. And these immunoglobulins are targets for the serological tests for Lyme disease. There are many international guidelines how to do it properly, so it's like standardized, and these guidelines are different among the United States, for example, and Europe, but generally the most common is two-tier methodology, when the first step is usually ELISA with really high sensitivity but lower specificity. And it's followed by second test, which usually is Western blot and is more specific. Here is the scheme proposed by CDC of the United States. So it's again the first test, the blue box on the left side, is usually ELISA. If it's negative, the physician should consider that the disease is not Lyme disease, or if he still thinks that the patient can have Lyme disease, the patient has symptoms, then the physician may consider to retest the patient again in several weeks. And if the test is positive, then the physician continues with the second test, which usually is Western blot, and now it depends on the duration of the infection. If it's less of this, if the symptoms are present for less than 30 days, IgM and IgG should be tested, and if the symptoms are present for more than 30 days, then IgG Western blot is only valuable to perform. We must be very careful with interpretation of Lyme disease tests. It can be said generally that in the beginning of the disease, IgM are positive, and later, at later stages, when the dissemination continues, only IgG should be positive. And there are many peculiarities, like it's really sometimes hard to decide whether the patient has Lyme disease or not. And I will now name several of them. Firstly, the IgG and IgM very often cross-react with other diseases, such as relapsing fever Borrelia relapsing fevers, as we were talking about before, or Treponema pallidum, which causes syphilis, that I will talk about later, or Leptospira, or even some autoimmune or inflammatory pathologies. In these cases, the tests may appear falsely positive. Then, if it's the early stage of the disease, the tests can be negative. This is called seronegative window because the immune response is not high yet. In these cases, sometimes it can help if the erythema migrans is present. You can see the erythema migrans in the picture. And this is a so-called pathognomonic symptom. Pathognomonic symptom means that it's really clear. We can be really sure that it's this disease, because in this case, erythema migrans is typical, which means pathognomonic for Lyme disease. And in this case, the physician doesn't need to wait for serological tests. If he sees erythema migrans, he can start with the antibiotic treatment immediately. And actually, he should start with the treatment immediately, so the bacteria will not spread through the whole body and cause more complications. If the patient was infected with Lyme disease in the past and gets infected again, it can be also tricky for the diagnostics, because he still can have IgG positive, because these immunoglobulins may last in the blood even for decades, and then it's hard for the physician to decide. In this case, the physician may repeat the tests, so he sees some fluctuations in the titer, so he is more sure if the disease is really present, and take it together with some symptoms. Yes, reinfection, I already mentioned. And false negative serology, this is actually very rare for Lyme disease. And there are only 2 cases that were reported in literature. Both of these patients had severe diseases. One of them was treated with glucocorticoid injections, and the latter one was treated with chronic lymphocytic leukemia. It means that both these patients had weaker immune response. They suffered for Lyme disease, but the tests were negative. Now I want to mention at the end of talking about Lyme disease, two misconceptions. As I said, it's really confirmed that the Lyme disease is present in Northern Hemisphere. However, there are some reports that this disease may be present also in South America. It's true that this bacterium, Lyme disease Borrelia, are present in some Ixodes tick species in the Southern Hemisphere, such as Ixodes pararicinus. But all these ticks that are known so far in South America, they do not bite humans. So until now, it has not been confirmed directly in the patients by direct methods such as microscopy or PCR. And again, I will repeat, these ticks, they do not bite humans. And as you will see in the next slide, when I will talk about the other misconception about Lyme disease, it may be related to this one, and it's the chronic Lyme disease. This concept is widely used in North America and increasingly in Europe, and it's very probable that it's imprecisely described condition. Patients who are called to have this chronic Lyme disease are believed to have persistent Borrelia burgdorferi infection, and they receive usually long-term antibiotic treatment, but their symptoms last. So it seems that they have chronic Lyme disease that is incurable. However, although this chronic Lyme disease concept probably encompasses post-Lyme disease syndrome, it also includes a wide array of illnesses or symptom complexes for which there is no reproducible or convincing scientific evidence of any relationship to Borrelia burgdorferi infection. These patients suffer for persistent pain or neurocognitive symptoms, fatigue, chronic fatigue, and some of them may, but some of them were not in contact with ticks, so they may never had Lyme disease itself. But as you already know, the serological tests very often they react falsely positive. So then the patients and the physicians, they think they suffer for the chronic Lyme disease. This unfortunately leads to prolonged and dangerous and expensive antibiotic treatment. So I believe that the public should be more informed about this problem. So that was all about the first two zoonoses. And now we will move to the treponemes. Here in this slide, you can see the main causative agent of human pathogenic treponematosis. And we will focus mainly on Treponema pallidum, subspecies pallidum, which causes the worldwide known disease syphilis. On this slide, however, I want to show briefly the distribution of so-called non-veneric endemic treponematosis. And this is Yos, Begel, and Pinta. As you can see, these diseases are present in warm parts of the world. And for Yos, it's true that it's present in areas with higher humidity. And for Begel, it's present more in more arid places with dry air. These diseases are not transmitted sexually. They are usually transmitted by direct contact, skin to skin, for example, among children. And syphilis, sexually transmitted disease, is caused by Treponema pallidum subspecies pallidum, and sometimes it's called stealth pathogen because it has the ability to hide, so the immune cells of the body cannot find them, and it leads to chronic diseases. Many people think that syphilis is a disease of history, and because we have penicillin, we don't need to worry. However, in last decades, it became again very dangerous because there are outbreaks in cities. Probably this is partially linked to the discovery of effective HIV treatment, because people do not need to worry so much about getting infected with HIV, and they may behave less carefully. So CDC, for example, reported increase by 81% from 2014 to 2018. So it's a huge outbreak. It can be said that it's distributed in the whole world, but in developed countries it's present more in gay communities or communities of sex workers. However, in developing countries, it affects more heterosexual populations. As you can see, the disease is very complex. I just wanted to show you. I will not go to details. As you can see, the typical course of the infection is primary syphilis that manifests with an ulcer, which is usually painless. The ulcer is presented on an area of the entry of the infection, such as genitals, oral cavity, or perigenital perianal area. And after several weeks or months, it may develop to secondary syphilis. In this stage, the bacteria is already spread in the body, and it may manifest with rash, with lesions. These lesions, together with the primary ulcer, are important for the diagnostics because you may spot the spirochetes in these lesions by taking swab. So you have a stick with cotton wool, for example, and you take swab from the lesion, and this is how you can get the spirochetes. This is very useful for direct detections such as PCR. Syphilis is also very tricky because it may turn to latent phases, which may take years or even decades, and it may manifest as neurosyphilis or other very severe symptoms, such as ocular syphilis, otic syphilis, and of course, it's very well known to cause abortions. For these reasons, it's very important to spot the disease at the early stage or before it will destroy the patient in more severe way. Until now, it's still sensitive to penicillin, and resistance to penicillin has not been described. But resistance to macrolides starts to be very common, and so physicians should know about this, that macrolide resistance becomes very common. Diagnostics of syphilis is usually based on serology, and there are a variety of tests, non-treponemal tests such as Venereal Disease Research Laboratory Test or RPR, and treponemal tests such as Treponematosis particle assay or hemagglutination assay. There is a lack of a gold standard test, but usually physicians follow combination of both of these tests. So they combine one non-treponemal test with one treponemal test. The non-treponemal tests are not so sensitive, but they are important because the titers decline rapidly after treatment. So this may help to the physician to know that the disease has been cured. And direct methods for diagnostics of syphilis are microscopy, or in the past was cultivation in rabbits. But nowadays, polymerase chain reaction, PCR, is very important, and it has been recommended by and confirmed that it's very important to combine it with serology by several authors, because it increases the sensitivity and specificity, as I will show you later. So it means if there are lesions and the physicians have possibility to take the swab from the lesion, they should always try then to keep the swab frozen, for example, prior the PCR testing, prior the DNA isolation and PCR testing. The diagnostics of syphilis is very difficult, and I will try to present you some of the challenges. Firstly, serology does not distinguish among syphilis and the endemic non-veneric treponematosis that you saw in the previous slides, which is Yos and Begel and Pinta. So the serology would be positive for all the diseases in the same way. For this reason, for example, PCR is also important because it can distinguish between these diseases. Secondly, the non-treponemal tests are very often negative during the early syphilis. In this case, it may help if the primary lesion is present or some other symptoms. In this case, the physician may repeat the non-treponemal tests after a short period of time, after several weeks. Sometimes it may happen that the non-treponemal test titers do not react to treatment. Then it's hard to decide for the physician. He should probably try to take sample of cerebrospinal fluid to exclude the danger of neurosyphilis. And treponemal tests, they may remain positive even after therapy. This is the case of almost 1/4 of patients treated in the early stage. They remain positive for years or decades after therapy. Diagnostics of neurosyphilis may be difficult. There are no standard tests, and although non-treponemal tests have high predictive value, they are less than 80% sensitive. PCR is not useful for cerebrospinal fluid because it's usually not so sensitive. And taking sample of the cerebrospinal fluid is difficult because it may easily be contaminated with blood. And blood may contain the immunoglobulins, and then the test would appear falsely positive even if the patient would not suffer for neurosyphilis. There are elderly persons that have positive syphilis tests and they have some neurological problems, cognitive dysfunctions, etc. Then again, it's hard for the physician to decide whether they really suffer for syphilis or the serological response is related to previous infection with syphilis. In this case, the history of the treatment of the patient that he was treated with syphilis would be very valuable. And now I will show how the PCR and serology is important, because in some cases, PCR may be positive, but serology negative. This may happen, for example, in the very early stage in the serological window of infection, when the treponemes are already present in high numbers in the primary ulcer, but the serological response is not high enough. But it can also happen that PCR is negative and serology is positive, as was published by Noda or Vrbova and colleagues. This may happen when the ulcer is already healed and no treponemes are present in the ulcer, but they may be present in blood. So in the secondary stage, it may be even important to take blood sample and try to do PCR from the blood. Or it may be the case that the ulcer is caused by other bacteria. This is very often Haemophilus ducreyi. And the patient may have been infected with syphilis in the past, for example. Now I will move to the last part of the presentation. It's more about genomes of treponemes. You can see a phylogenetic tree that contains causative agents of syphilis and also Soyos and Begel. So you can see that they are closely related. And the syphilis strains, they cluster in two distinct groups, and they were named after some strains, SS14 and Nichols. So they are called SS14-like strains and Nichols-like strains. Some studies showed that nowadays the Nichols-like strains are more distantly related to each other. They are not so widespread in the world. They were collected mainly in the United States. And in contrary, the SS14-like strains are more closely related to each other. They were present in most of the places that were sampled, and they very often contain mutations that lead to resistance to antibiotics. This is shown by the dot in the middle of the circles. There are some theories why there are these two groups of syphilis strains. One is that they were evolving in other parts of the world separately. Other theory says that the SS14-like strains they developed more recently, and because they were more invasive, they spread around the world. But because we don't have information from the past, it's very hard to decide. There are also some experiments that suggest that these two groups may have really different pathological potentials. So it's really very important to try to describe the diversity of syphilis strains in the world. This is currently the map, the distribution of known Nichols-like and SS14-like isolates. As you can see, most of them belong to the SS14-like group. They are more prevalent, and Nichols-like isolates were found only in some parts of the world, like surprisingly Madagascar, Argentina, or Peru. And also you may see large wide areas of the world that were not tested at all, so we don't know anything about the diversity of the syphilis strain in these areas of the world. So this would be very valuable if you had chance to sample patients in these areas of the world and make a PCR, as I will show you later, to help to describe the diversity of syphilis. There were some multi-locus sequence typing schemes developed, for example, by CDC, and my colleagues, namely Linda Grilova, they developed like enhanced multi-locus sequence typing scheme. It's based on 4 loci, so it's 4 PCRs. 3 of them are highly are 3 genes with high discriminative power, and the 4th one, 23S rRNA, tells us about the macrolide resistance in the particular isolate. This multi-locus sequence typing scheme helps to distinguish not only between the syphilis, Yos, and Begel strains, firstly, it also tells us about the diversity within the syphilis group, and it tells us if the strain belongs to the Nichols-like or SS14-like group. And also, as I already said, if there is the macrolide resistance present in the particular isolate. If you had chance to amplify such isolate, you may upload it in the public database pubmlst.org. So I highly encourage you to do, because it would really help to describe the diversity, the current diversity of syphilis in the world, and especially in this period when this disease has its outbreak. I would like to conclude in the end of this presentation that diagnostics of the relapsing fevers, Lyme disease and syphilis is very difficult. Generally, it can be said that relapsing fevers and syphilis are underestimated, and in contrary, Lyme disease is substantially overestimated, with large number of false positive cases. The physicians should always decide based on the whole clinical picture and not rely solely on the serology, because solely the positive serological result without any clinical symptoms should not be treated with antibiotics. Here are links to the references that were used for the creation of this presentation. Now I would like to thank you for your attention. And eu queria agradecer à Universidade Estadual do Maranhão, and also to my colleagues, to our leader, Professor David Mais, and also Linda Grilova and other colleagues for their participation in our research. Thank you.
Thank you, Markéta. Thank you very much. It was a great presentation. It was ours to hear always. So, we have two questions, okay?
Okay.
Are you ready for you? Lu, serologic tests are more cheaper than the forms of direct detection. So, serologic test is not expensive or direct detection.
Serological test is indirect detection.
Serologic tests are more cheaper. It's very cheaper than the forms of direct detection. Did you understand?
Yes, I understand. Yes, generally, yes, because for indirect detection, usually you only buy a kit and you perform the test. But for direct detection, like PCR, the physician would need to have access to the laboratory that will make the PCR for him, or so maybe it's more difficult and maybe more expensive in some parts of the world.
Okay. What the question? Everyone who are infected with primary syphilis can develop to secondary syphilis?
No, this doesn't happen always. It always depends on the immunity of the patient and on the dose that he became infected with. Million treponemes or 10 treponemes. It always depends on this.
Okay. So let's talk about Portuguese. Any question? More question? No? Finish? Markéta, thank you very much por aceitar o nosso convite. A Universidade Estadual do Maranhão agradece muito e sempre vamos querer ouvi-la sobre temas muito importantes, não só para a Europa, mas para a África, Ásia, América, como todo. São temas muito relevantes e de uma grande importância, porque são zoonoses. Sim? E muito obrigado.
Eu também agradeço muito, Chico, por me aceitar neste evento.
Muito obrigado por aceitar o nosso convite. E mais questões? Não mais questões. Então, Markéta, nós teremos uma próxima palestra agora. E muito obrigado.
De nada.
Às 15h30, a próxima palestra. Então, bye. Thank you very much.